pre-op, post-op packet. And some of this you had a long time ago, but it is not hard. It's so simple. Stuff you probably learned in clinicals, but we're gonna write it on the front of the page. Yep, there you go, pre-op checklist. We're writing everything on the front of the page, but everything on my board is inside of there really nicely. But you can still write it on the front, it's a nice study guide. Who removes the first dressing? The surgeon, good, write it. Doctor removes the first dressing. Okay, so surgeon removes the first dressing post-op. What can you do? Only reinforce it. If there's something going on, you can reinforce it. Of course, you're keeping them informed, but you don't remove it. So the doctor removes the dressing. When there's drainage on the dressing post-op, and this is every single patient I've ever touched that had drainage, I circled it, I put the time, I put the date, I wrote my initials, and here's the kicker. I went and checked it again in 1 hour. I'll say that again. If your patient is having some bleeding on the dressing, you're going to circle the area itself, time it, date it, initial it, and check it in 1 hour. It may never go beyond that little circle you made, which is fine, but it could be hemorrhaging, so you don't know until you check it an hour later. Okay. Open to air allows for the wound, just write the crazy language that I wrote, because that's what you gotta know. Allows for wound edge adherence. Open to air, keeping the dressing off, allows for wound edge adherence and promotes healing. In order for wounds to heal, there must be blood supply and circulation to tissue. In order for wounds to heal, there must be blood supply and circulation to the tissue. That's the first step in wound healing. You ain't got no blood supply because your patient is anemic as all hell, we're going to have a problem. Or their blood pressure's so low there's no perfusion. Never remove scabs. Never remove scabs. On the front page, highlight consent form. On the front page, and make it your #1 priority. Your job, the nurse's responsibility, is to witness, and you can't do that if you're not there, so let me hear you out there lying somewhere, so I'll come and hunt you down. We've had people witness the damn form the doctor ain't even in the hospital. Don't do that, and don't ever get them signed. You are there merely to witness and verify that the patient understands. I'll never forget it. My patient didn't understand. I went in there talking about, do you know what you're here for today? Mm-hmm. Doctor finna fix my periods. Well, good, yeah, that's about right. When we take out your uterus, we certainly do fix your. Wait a minute, what'd you say? Take out my uterus? He ain't told me nothing about taking out my uterus. Really? Physician's lounge. Hi, Doc. I'm sorry about it, but you know your patient here for a badge his? She knows nothing about what you're doing. That's bullshit. I told her about. No, I'm serious. She don't know what you're doing. Oh my God! What the fuck? He comes out yelling. Then he starts yelling at her. I told you I was taking out your uterus, Mrs. So-and-so. I told you that in the office. You ain't, that's what she said. You ain't told me nothing about taking out my damn uterus. No, you didn't. Guess what, y'all? She walked out with her freaking uterus. She had no idea what you were doing to her. That's a nurse's job. Verify the patient really understands. How do you do that? What are you having done today, honey? Okay? So that's that. Now, timeout. Write your timeout on that page. Write your timeout procedure. This is to minimize operating on the wrong limb. Shit still happens. We get about 3 a month in America. Oh yeah. Operating on the wrong limb. Who participates? Everybody in the OR, including the patient. Everybody in the OR. Why are we all here today? To operate on Mrs. So-and-so's left breast. Mrs. So-and-so, do you agree? Yes, I do. Everybody participates. Okay, so that's time out right before you're doing any surgery. Your complications, write them on the bottom. Oh, you know what? They're actually listed, I think. Hold on, please. Look at that page. Turn one page. Turn 2 pages. 3. Aha. The one that says post-op complications. Boom. In the middle of the page, it says post-op complications. On the left-hand side, you got plenty of room. These are your post-op complications. And I'm going to go over them, but you just write them over on that side of the paper. Obviously, you have a whole section in that packet on this, but I'm just going to tell you little highlights. So anesthesia complications is the most deadly complication. And one of the reasons is something called malignant hyperthermia. The number one question you can ask your patient to prevent this is, has anybody ever died in the OR or immediately after surgery in your family? Has anyone ever died in the operating room or immediately after surgery in your family? Because this is genetic. We only see it with general anesthesia. The number one medication is succinylcholine, and I'm positive I spelled that wrong. Succinylcholine, that's how you're going to think. So again, malignant hyperthermia. Has anybody in your family ever died in the OR or right after surgery? You only see it with general anesthetic, which is going to use the medication succinylcholine. That's the number one medication used during a general that can trigger it. The symptoms in your patient, real quick, the number one symptom is not that fever. That's a latent sign. It's going to be tachycardia. Tachycardia first, high-grade fever, 105, 107, 110, something stupid, 110. Can you believe that? It's crazy as hell. That's going to be what you see, but you're going to see tachycardia first. And a clenched jaw. Patient's body is rigid, but they're under anesthesia, so you can't tell. So the only thing you can tell is the jaw. It's like clenched, because it's muscle rigidity. And so because technically they're having muscle rigidity, and you do want to write that, muscle rigidity, you give them dantrolene, which is a muscle relaxer. Dantrolene, which is a muscle relaxer. The cure for this outrageously deadly condition is a hyperbaric oxygen chamber. Hyperbaric oxygen chamber. So what if the patient said, yeah, my sister died in the operating room. They said she had some fever thing going on. This patient's not going to get a general anesthetic. They're going to get a muscle biopsy, which is going to diagnose their genetic condition. If someone says yes to you, you're not getting a general anesthetic. Instead, they usually order a muscle biopsy. And like I said, everything is in your packet when you just write down these little quickie notes. All this shit's in there. Okay? All right now. The next complication is hemorrhage. How do you know? Well, tachycardia. And watch the drains. Bright red blood in any drain, and they call it free flowing, is hemorrhaging. Bright red free flowing blood in any drain is hemorrhaging. Whether it's an NG tube, a chest tube, a Foley, bright red free flowing. Could be the TURP patient. The TURP patient's doing bright red free flowing, it's an emergency, it's hemorrhaging. DVT-PE, boom. Respiratory song, every bit of the respiratory song, every bit of it, and then you add to it chest pain and hemoptysis. And the fact that the patient is post-op is going to clue you in that they're having a PE. All of this respiratory song, chest pain, and hemoptysis happens all of a sudden. Boom, they got a PE. They may or may not show you the DVT. Sometimes we don't know they have it. But all PEs started as a DVT. How do you prevent it?
Ambulation.
Ambulation within 6 hours of surgery. Pneumonia, don't forget the goofy word, atelectasis. Atelectasis is collapse of the alveoli, and it is a precursor. Preoperatively, if your patient does not deep breathe, and remember deep breathing is more important than an incentive spirometer, but an incentive spirometer is critical. But if you had to choose one on the test, always pick cough and deep breathe first. Because gadgets are last, nursing care is first. Okay? Infection, 2 things. Tachycardia could also mean infection, and in elderly patients, a change in mental status is usually one of the signs. I put all 5 of those in bright red, and I put bowel obstruction in dark red, because it doesn't necessarily happen right away, and it's not necessarily who you see first, but it is a complication. On your test, maybe they'll say the words paralytic ileus. The bowel is paralyzed. Paralytic ileus. So the complication post-op is that the patient has a bowel obstruction, which is called a paralytic ileus. And if that's true, you have to be NPO. Now, when do we feed our patients? Only when bowel sounds return. We only advance the diet when bowel sounds return. When do they return? Within about 6 hours post-op. Are they there 2 hours? No. But within 6 hours post-op, most patients' bowel sounds have returned. Do not look for bowel sounds to be there. You can check for them, but don't expect them to be there an hour post-op. 6 hours, 10 hours, 12 hours. Yeah, where are they? Don't feed them till you hear them. Okay. All right, so that's good. Now, this crap here scale.